Okay, so questions from last week.
So if we turned in the assignment, you graded it, and we got lower 4, said it fixed something. If we turn it back in, it won't be considered late load.
No, if you turned it in on time originally, it won't be considered late if you turn it in fixing the things that I asked you to fix. The discussions as well, if some did both of their responses and some didn't. So please do the responses so that you can get credit for those. Overall, I thought the discussions were reasonable. The discussion this week, however, is going to be about the Surgeon General's report on smoking and what effects that it's had. If you read my post, there's quite a bit of information that I've started off with, but what I want you to do is do your own research, draw your own conclusions, and support them. You can go back and get all of the Surgeon General's reports if you have 50, if you want 50 years worth of documents on your computer. But there's a lot of information out there. There's also a lot more, and some stuff I will go into later this week as well. What we want to do tonight really is go back and look at last week's discussion about public health crises. Now, you, I think, picked on smoking. Right?
No?
Someone did.
I was picking on the opioids.
Randy, you did. Oh yeah, you picked on opioids. And that is a major public health crisis, opioid addiction. And Richard, you still have some things to catch up on from last week. I'm going to give you, I can understand going through what you're doing. We're probably going to end up there sometime in God knows what future with my 98-year-old mother-in-law who, her cardiac surgeon says her pacemaker is going to last at least 2.5 more years. So we don't know what the future is. So we anticipate going through that. So I can be very sympathetic. But go ahead and get the work done, get it turned in. I'd like to see it in the next few days. Okay. If you need to make another fast run to Cheyenne, just let us know. Okay, just send an email to me or Christy or Amanda or somebody, and we'll let people know. Okay. So lots of public health crises out there, the nature of public health is that you can't give it a pill. That's one of the differences. Pardon?
We do far too much of that already.
Well, we do, but and sometimes I think it's useful. I used to be very negative about a lot of long-term drugs like antidepressants. And the reason I was negative is because, and I still feel this way, I do believe that there should be no use of those things without concomitant counseling, because they just basically hide the symptoms. They make you appear functional in society. And I've watched too many people look like they're functional and they're not. But we went through a spell with my mother-in-law where she was just really, why am I here? I just want to die. And put her on a low dose of an antidepressant. and she started telling jokes again, doing all sorts of things that she hadn't been doing before, and we hadn't quite picked up on weren't happening. So my view has modified. I still am not a big fan of them by any stretch of the imagination, but my view now has been modified a little bit in that I see more of a use for it. And so that actually does work for some things. And it actually can help. The fact that it's helped my mother-in-law is almost a surprise for me, because it happened within a matter of a couple of days, and usually we're looking at 2 weeks before you start seeing any effect. And it made things so much easier for me, and especially for my wife, that I see now that there are places, and I intellectually knew this, but there are times and places where they're useful. And we have a social worker working with us, so we're getting a little bit of that outside help. So, to us, it was as much good for us as it was for her. So we get the effect without taking the pill, So not bad.
Well, I think my biggest issue, and this comes from now working in a pharmacy,
Yeah.
is the fact that insurance companies are so much more willing to cover an antidepressant, the full amount of it, than they are, like levothyroxine or insulin. They'll cover antidepressants and opioids so easily. It's not even much of an argument with them.
Mm-hmm.
But when it comes to, well, this person needs their insulin. Okay, prior authorization. Okay, but they get this every month. They've been getting it every month.
Mm-hmm.
Why do they suddenly need this prior authorization? Because they need it.
Yeah, there's
Okay.
an issue for sure. Diabetes is not a disease that comes and goes. That is said with a little bit of caveat, because we're starting to see some places where people can ameliorate their disease. But if you're insulin dependent, it's much different.
Yeah.
So once you've had an insulin dependent diabetes diagnosis, that shouldn't have to be repeated.
But that's the thing.
And the authorization should be in the records as
right.
an authorization.
And that's the thing is we had a lady come in that she's been getting her insulin with us since before I even started school here.
Mm-hmm.
And she had a prior authorization early on. And then today she comes in and her insurance is refusing to cover it. We finally get on the phone with them and they're like, oh, well, we need a prior authorization. She had one when she was diagnosed. Well, we need a new one. Nothing about her prescription has changed. And it's just, and I'm just sitting there going, okay, as I'm also handing out everybody's hydrocodone, acetaminophen, and Percocet.
Yeah.
And they're getting it for free. And it's I sit there and don't get me wrong, I do believe that some of the people truly need their pain medication, spinal fractures and stuff like that. But there's some of them that it's why are you still getting this after 4 months?
Yeah.
And I've never seen a prior authorization for you.
Right. You mentioned spinal fractures. In reality, the pain from a spinal fracture, generally speaking, unless it's displaced. If someone just falls and cracks a vertebra,
right,
that pain only lasts about 6 weeks.
Well, we have a couple people that I'm not sure
And there's,
the
that's,
extent. Yeah.
that's atypical. That doesn't
Right.
say that everybody's the same way. But for the most part, unless you have something that is displaced or really ruptured, if it's, because again, with my mother-in-law, that's when she fell recently, and we figure she must have cracked a vertebra because for various reasons, we had to have her have an X-ray of her lower spine and pelvic area recently, and the remark from the radiologist reading it was um, a cracked vertebra was, an older cracked vertebra was seen in this, and she's never, and we knew she started having pain from the instant she fell. My wife, as a physical therapist, has seen this many times, so we sort of figured that might have happened. But she's such a tough old bird; she won't take anything for it. We finally have her taking some Tylenol once in a while. And that's it. Which is all right with me. I don't particularly have any need to have opioids in the house. And but about 6 weeks later, she wasn't complaining of back pain anymore.
Yeah.
So again, how many doctors actually understand that? Not many.
Well, and I'm starting to wonder how many of them actually understand what Adderall and Ritalin and Concerta can be used for, because I must fill and take in at least 100 of them a day. And
Narcolepsy.
we do have a lady.
Yeah.
That she gets her
Narcolepsy is,
Concerta.
we think of those as mainly ADHD.
Yeah.
We're starting now to heavily diagnosed adult ADHD.
Yeah.
And so that's why we're seeing, this is another area, a part of public health is medicine as a way to just control people.
Yeah.
But yeah, I know a number of adults who have been diagnosed with ADHD, and they seem to live that diagnosis because they can get a medication for it. And by God, what is it? It's a stimulant. You feel pretty good when you take that stuff, I'm told. I mean, it's an amphetamine.
Yeah. Well, and then it's just, I think the part about it that gets me is that we have to, check to see when they last filled it before we can fill it again and all of that. And I go into their records and they've got antidepressants and all of this other medication. And I'm sitting there going,
Well,
like, connections not being made here.
when you see something like that, do you point it out to your pharmacist?
Mm-hmm.
Good.
And
Because
I mean, Carol Ann is very good.
yeah,
She's
Okay.
very picky. She's very particular. She scrutinizes every prescription that comes across her desk.
good.
But with some of them, especially the ones where it's like, we've got this year-long history of all of these medications where they've been filling it at different Walgreens and then come to us, she just kind of pinches herself. And you can tell that she hates having to just fill it. But it's like, if we've already been doing it, her suddenly turning around.
But it's a different pharmacist in a different
Yeah.
location. The other thing is that all of those drugs interact. I mean, this is another crisis. This is another public health issue, really. So it's actually a good thing to mention in this class. But the whole issue of overprescription of psychoactive substances, antidepressants, anxiolytics, stimulants like Ritalin and Adderall, and
They can have
And all the
nasty
others.
interactions with each other.
they can have some pretty nasty interactions. And I can remember my wife used to, when she was in home health, one of the things that the first professional into a home health visit had to do is a very it's like 35 pages of paperwork to start up a patient. And when my wife first got into home health 40 years ago, it was 2 pages.
Mhm.
And now it's 35, or it was 35 a few years ago. She hasn't been practicing for a few years now. But nonetheless, one of the things is they have to go through and confirm what medications the patient is taking. Physical therapists are not trained in medication.
No.
So all she can do is take a list. So one time she brought me a list and, no names or anything on it. So we're pretty careful about HIPAA things around our house. She brought me this list of medications and she said, what do you think of this list? There were 28 meds. 3 antidepressants. 3. And several other things were duplicate sort of medication. And I said, is he taking all of these now? Is he taking all of them, or is this his list from the past year? No, he says he's taking every single one of them. I said, take it to your nurse. Somebody needs to be looking at this because this guy's going to get killed.
We actually had that happen because one of the other girls, she was looking at this patient's profile and she calls me over and she's like, am I insane or do a lot of these do the exact same thing? And I mean, these were ones we were filling on a monthly basis for this person. And sadly I was sleep idled at the time, so I can't remember what half of them were even for, but it was the same thing.
Yeah.
There was like 2 different blood pressure medications. There was, and
That's not unusual. You'll find patients taking up to 5 separate types of meds. Now, if it's 2 different beta blockers, that's one thing.
But we go and give it over to my pharmacist,
Yeah.
and my pharmacist told the patient, I cannot let you leave with these medications. And she called the doctor, and the doctor was like, no, I was not aware that we had all of these medications on this patient. Come to find out, the doctor and the PA weren't talking to each other. And were just
and they
prescribing.
should have been looking at the chart,
Yeah.
at each visit and seeing that these things were prescribed. But it happens that way.
Yeah.
Years ago, when my mother was in the hospital and had some surgery, she was at Walter Reed in D.C. And I walked in and I'm nosy, so I go look at her meds. I want to see what her medications are. And so I look down and she's taking Maalox, Tagamet, and Zantac. Okay, I understand Maalox and either Tagamet or Zantac because they're 2 different mechanisms of action. And they really are trying to, since she couldn't take anything, they were trying to make sure that her stomach didn't get too acidified. So, but I said, why is she taking 2 H2 blockers? And the doctor I asked this to looked down and he goes, I'm not sure. Turned out 2 different doctors giving their favorite drug and not working together. The next time I went up, one of them was gone.
Well, that's the other problem I've noticed is that the doctors have their favorites.
They do.
And that's all they'll prescribe.
Yes, and see, this is where a system like they have in France, and I know I've discussed this topic before, the smart card. In France, it's a single payer system, so the government is the payer. The doctors, just like they are in this country, are all independent practitioners, and they get certified to be reimbursed by the government. And that's it. They have hospital privileges, they have their own practices. The structure of medicine is exactly the same, except single payer and a smart card. So if you live in Paris and you go driving down to the south of France and have an automobile accident on the way and are unconscious, they pull your smart card out of your wallet, swipe it, they know exactly what your medical history is, they know exactly what drugs you're on, they know everything about you medically that they need to know. And in medicine in France, they don't change the meds that you've already been prescribed by another physician. They don't know the patient, and they understand that they don't know the patient. So you've got that, and their system actually it works pretty well for preventing the kinds of things we have here. Here, we've been able to sort of roadblock this with my mother-in-law because we know how things work. But you go into the hospital, and what happens? First thing they do is they take you off all your meds and put you on what they think you ought to be on. Well, you can't do that to patients. You can't jack around their biology that way. So we've interfered with that with my mother-in-law a couple of times. And then if you happen to go from a hospital to, say, a rehab center for a couple of weeks,
They do
the people at the rehab center do exactly the same thing. So you've jacked around twice with the medications. And then when you go home from the rehab, they don't even give you medicine to go home with. They tell you, go back to your doctor and get your prescriptions filled. So, this is something that needs not to be the case. It's ego. I know how to treat this patient better than you, even if I've never seen the patient before. But I will say one thing. Northern Colorado Rehab in Johnstown, when my mother-in-law broke her femur and was sent there from the hospital, they made sure they knew what meds she was taking. We handed them the list, and they made darn sure that she stayed consistent. So I was real pleased with them. So there are places that are understanding that we can't play games like that. And these people, that's probably the best rehab hospital I've ever seen. They are good. So if you ever need a rehab hospital,
Yeah,
Northern Colorado and Johnstown, right off 30, right on 34. Good place. But because they don't do meds. I mean, they'll do pain meds. I mean, you have to do that when you're in rehab. They don't do meds. So they look at what the patient's supposed to have, and they stay with it, which is a bright way to do things. I liked the attitude they had. But
Well, in the hospital at Cheyenne, I just kind of assume that's how they did it everywhere. But when you go in, they do all your medicines, but they don't take your medicines. They give you medicines from the hospital, but it's all your prescriptions.
yeah. That's the way they should.
Yeah, I thought it was just done everywhere like that.
That's the way they should. I mean,
because that seems common sense.
It does. It does. Theoretically, they could easily just use your meds, but of course, they make a lot of money on meds.
And then there was one medicine that she only had like a couple days left, and they just told her, just take those that you have. She only had like 3 pills left or something.
Yeah.
They said, yeah, just take those, and we'll be done with that.
Yeah. Well, now that she's in hospice, she won't be taking her meds.
Well, they do all, what do they call it? Comfort meds. So that includes high blood pressure, but a lot that I didn't realize.
Yeah.
So and it won't do insulin. Insulin, they consider that treating your disease, so they won't do that.
Yeah. Yeah. Well, they want the patient to be comfortable. They don't want to precipitate death. So they try to control their blood pressure, control their pain. But, it depends on what their problems are. I mean, when one of our friends ended up on home hospice for the last several weeks of his life, I mean, he had multiple cancers that he was dealing with. And the only thing they had him on was something for the pain. But by the time we managed to get down to Salida to see him, he was already unconscious. So, he didn't need anything. But but that was.
And I want to say she's still taking Lasix too.
Well.
And
yeah.
That was a problem. None of the other ones were working, and then right at the end there, the Lasix started working. So. But I was surprised that they were still taking that too, or giving it to her.
Well, but that is helping her blood pressure.
Mm-hmm. Yeah. Okay.
By volume reduction.
That might be the way, not for the heart disease.
Yeah, that's helping with that.
Okay.
The volume reduction puts a lot less
Definitely
strain on the system.
blood pressure.
So, yeah. But it's interesting what the things you learn when you have someone going into something like that.
And is that a state by state thing, or is that federal?
Yeah, they're state by state. Hospice is all licensed by the state, and
Once they decided that, they take everything, pay everything 100%.
yeah, yeah. Well, they should.
Mhm.
They should, because it's actually cheaper, especially if you have home hospice. It's actually a heck of a lot cheaper than any other thing you can do medically.
And so I was kind of
Because
surprised because when she got out of there too, she was way better than at any time she was in the hospital. So I was wondering about, well, how long is this going to last? And they did the first thing is for 6 months, first block.
Yeah,
And then after that, you have to get recertified.
yeah, because what we see sometimes, and this is something my wife saw, was she had a patient who went into hospice. So they took her off all her meds, except for the comfort meds, and she got better. So they sent her home. She went back on her meds. A few months later, she was back in hospice. Took her off her meds. She got better. They sent her home. And this is where the medical profession is a very slow bunch of learners. They put her back on all her blasted meds again. And this time they managed to kill her.
Yeah, because I thought too, I was like, come on, guys, she's been laying in bed for 10 days. She needs some kind of physical therapy just to loosen her torso up and stuff. I'm sure that'll help her breathe too.
Well, it is an interesting place. Hospice care, palliative care is kind of an interesting thing. I mean, basically, other than my mother-in-law staying on all of her medications and so forth, she might as well be in hospice. I mean, we can take her out, we do, but she's just not. She's not getting any other care. I mean, she'll go into the hospital and then they'll send out home health for a few days, but that's it. So it'll be interesting. Anyway, so the opioids, every year, I think in 2017, I think the figure was there were 7,000 more opioid deaths in this country than in 2016. And it's been rising every year. And more people on opioids are the elderly. And why? Because they're given these things because they've had deteriorations, they've had injuries, whatever, and they end up with them on, basically for life. And we're seeing significant rise in the elderly now dying from opioid overdoses. I mean, all the publicities for these young actors and stuff that kill themselves with drugs, but in reality, the real problem is the general problem that we have with the overuse of these drugs.
Well, it doesn't help that you can get 100 of them for $20.
That is a problem.
And that's without insurance.
So it can be a problem. And the fact is that first off, they're dirt cheap, and they're the patient's paying $20, but they're dirt cheap to manufacture, so the margins are huge. For most prescription drugs, the gross margin, meaning the difference between the sales price and the actual production cost, the gross margin is more than 99%. Now, there's a lot of middlemen in there that take a chunk of it, but the pharmaceutical industry has enormous profitability because the stuff they make is easy and cheap to make. Very few drugs are difficult to manufacture. There are a few that are extremely difficult to manufacture, but all they do is jack the price. You know, there was a drug approved.
Well, it's like morphine right now, the tablets. You can get 120 of them for $35 at a Walgreens without insurance.
Without insurance.
That's without insurance. That's people who, well, I don't have insurance. So how much is this? $35?
Mhm.
Oh, I hate it because there are a lot of people who don't have insurance that they're getting put on these medications, and they come in and they're like, and they sit there like they're holding a time bomb, which I understand. The mentality there is, well, these are so addictive, they must be super expensive. And then they ask me, how much is this without insurance? Because I don't have any. And I'm sitting there going, I don't want to tell you. I want to tell you that it's going to be $300 without insurance, but I can't lie to you.
Mm-mm. And yet other drugs that people need are hideously expensive, not
A
covered by insurance.
10 ml vial of insulin is almost $500. Like this is somebody's life force right here.
Yeah.
And I have to tell people who don't have insurance, you're looking at about $500 a vial, and you need 5 of them to get through the month.
Yep. There again, it's one of the issues with our current health system. But let's go back to public health issues. And that is, in a way, part of a public health issue.
Yeah.
And it's not one that's ever going to be addressed because
Because it makes money.
it makes money, and the drug industry owns the politicians. I mean, to be just blunt about it, they own the politicians. That's all you need. You have enough politicians in your pocket, you get what you want. And what they want is a system. You know, when Medicare D was passed, finally, the lobbyists made sure that the legislation included a prohibition on the government actually negotiating prices with the pharmaceutical industry. So they had to pay full freight. Now the VA does. They have contracts and they negotiate prices, but Medicare can't by law, which is, you know, you ought to go through in my book, you ought to go through the congressional record, figure out who voted for that, and then start getting them out because they're not working for us. Now, I'm lucky. I don't take prescription medications yet. Will I? I don't know. If I'm like my dad, it'll be pretty minimal. As I get, even if I live into my 90s and up to 100 like he, you know, it'll be minimal. But I have so many friends that are on so many medications already. Some of them 10 and 15 years younger than me. Chronic meds that I don't see how they, you know, I don't see, you know, how they can afford it. Their insurance pays for it, obviously. And when they get up to Medicare age, the Medicare will pick it up. But we'll see. But it is really a public health issue because, as you point out, if someone is a diabetic and has, say, fixed income, $500 a vial is not affordable.
No.
Not unless your fixed income comes from being a trust fund baby and you've got, $20,000 a month coming in. But
Well,
even then,
I mean, it doesn't help, even with Medicaid aside, even with other insurances, they only cover so much of it. And I talked to one of my friends who does the phone negotiations she's tech support basically for one of and I asked her about that, and she's like, because we can make a shit ton of money. If we only cover this much of a med that's this much, we make more from what they pay us.
Mhm.
And it's like, that's painful.
it is the system. And
It's a stupid system.
well, it is a system that is headed for a train wreck. And at which point we'll see what happens. But
The U.S.
just
will
don't know.
implode on itself.
Pardon?
The U.S. will implode on itself.
That's possible. So anyway, among other, so you wrote about opioids, you wrote about smoking. This week's discussion is about smoking, so we'll get back to that. Richard, what was
Mine's heart disease and stroke.
heart disease and stroke? Yeah. And those are often lifestyle related diseases from diet and lack of exercise and sometimes people just drop dead. I mean, their hearts just stop beating and they're otherwise
Right, otherwise
healthy.
I think they can pretty much prevent it.
Yeah.
So I think, so this is just 250 words. I'm almost done with it, but I'm pretty much just saying that, that should be, I think it'd be more affordable to make sure that kids have that kind of education and get to see the doctor normally, regularly, so that we don't have to foot that bill for their diabetes and stuff later.
Mm-hmm. And diabetes is an interesting one. We haven't talked much about metabolic disease like diabetes. Diabetes appears to have a number of things about it that may or may not have been anticipated. And the reason I say that is because the two countries with the largest population of diabetics in the world are India and China. And, we think about diabetes, and we're talking about mainly adult onset, type 2 diabetes here. We normally think about diabetes as being something that comes from the Western world where we have these fatty diets. India is a Hindu nation, and the Hindus that and most of them actually adhere fairly closely to the Hindu dietary restrictions. So they're vegetarians. And many of them are vegan. So you'd think that those kinds of diets would be more healthy. But the problem is the countries are modernizing and the diets are changing. And so we're seeing just huge numbers. I think I read 63 million diabetics in China.
Well, see, China, it doesn't surprise me as much. And I think it's just because of how fast they modernized. I mean, there's a Chinese fad going on right now where a lot of the Chinese Instagram famous people, what they do is they go and they eat obscene amounts of the Americanized food.
Mm-hmm.
And it's from this culture where relatively healthy diets compared to what we eat, to be going to that, it's what are you doing to yourself?
Yeah. It's part of the materialistic view, but yeah, there's that. India's not too far behind, and the interesting thing is that McDonald's is in India, but they don't sell hamburgers.
Well, they can't.
Well, they
Hindus don't
could.
believe in eating beef.
There are a number of Christians and others in India.
Right.
The state of Kerala is largely Catholic. because it was colonized originally by Catholics, mainly from Portugal. And Goa is a Catholic town. So there's quite a few Indian, but not that many as a proportion of the society. It's not a big amount. But yeah, but they're there, but they can have other aspects of their diet. I mean, there's nothing that says that a vegetarian can't eat French fries cooked in coconut oil.
True.
You know, and although coconut oil is one of the big health fads these days, I think it's baloney.
It's still oil.
Well, it's fat. I mean, literally, it is the most saturated of the plant fats. Very much, very much.
Well, it's just
Which
like
is why it's so solid at room temperature.
Yeah. Well, it's like it's like when all the restaurants changed to sunflower seed oil instead of peanut oil. It's like it's still just as bad, but everybody thought it was this big health thing.
Yeah.
The reason they
Well,
did
now
it
it's
was
avocado oil.
Cheaper.
No, actually, the reason a lot of restaurants stopped using the peanut oil was because of the allergy.
Yeah.
You'd have this entire group of people that refused to eat out because if you use peanut oil, I'm going to die.
Yeah, and if it's bad at all, yeah, they probably shouldn't be going anywhere. I mean, you go into a store and you touch something somebody else touched that had peanut, you'd be sick.
Yep. My sister-in-law is so allergic to tree nuts that if her husband had a nut at lunch and then came home at night and kissed her, her lips would tingle. 6 hours later.
You cheated on me with a tree nut.
That's right. That's right. But so when she was out here for our daughter's wedding, we took all the nuts out of the house. We squirreled them away and looked at my mother-in-law and said, "Forget it. For the next several weeks, you're not having any." And she was perfectly fine with that. But as a result, you have to be careful. You have to be careful because I can remember being in a restaurant and she bit something and spit it on her plate and ran out of the room. And people are looking at me and I said, "Oh crap, some nuts in it." So she was okay, but I mean it does happen. But but the issues here of the various public health stuff. I mean, every day we read about issues in public health. One major issue, and we'll get into that in some of the stuff we'll talk about after we take a break in a few minutes, has to do with the relationship between social and what is it? SES. Social and educational status. The issues there are that the lower people in the socioeconomic status, the people at the lower end of the rung of the socioeconomic status, by and large, are less healthy than people higher up. And it's all status. It's all about money. The very rich can afford medical care and can afford to maintain health. The well-educated understand, some of them still engage in unhealthy activities and lifestyles, but for the most part,
rich enough to do so.
Yeah, but for the most part, they have a better understanding of the needs of diet and exercise and other things, and so they tend to be a little healthier. So, and if you happen to be in a minority, Hispanic, Black, Native American, any of those, then your health is at the bottom of the rung in our society. And it's because of the delivery system, it's in part, and it's also in part because can't afford it. healthcare gets out of reach. There are plenty of places that try to deliver good healthcare, and the people that work in delivery of healthcare and the emergency rooms and other structures have to admire them, because they've got a tough job, you know, and they're not, and many of them are not doing it for the money. Well, actually, that's not true. Some of them are doing it for the money because they need the money to pay off their medical school debts. My physician, my primary care physician when I lived in Arvada, was a young man who once a month would go down to Pueblo and work several days, you know, pretty much around the clock in their ER. And that's how he
Place
was.
to do it. You'll get all your hours.
And it was actually, the amount of money he was paid was paying his school debt.
I'm really not surprised.
Yeah. So, you know.
I've got a portion of my ex-husband's family that's down there, and the number of it's every other day.
Mhm.
One of them's making a trip to the ER, and it's just like, I go to the ER once a year, maybe, and it's always something. It's always just because it's like, okay, it's 9 o'clock at night. Nowhere else is open.
Yeah. Well.
When I was at Fort Sam, in the emergency room there, the doctors that were going to be residents, they did some of their internship. They would have been Taub Trauma Center in Houston. And he said those doctors wore flak jackets. And it's the one at the door. All he did was intubate people. If you were breathing, they just kept moving. If you weren't breathing, he intubated you. That's all they
I
did.
believe it.
Well,
Let's take a break. So what you do is you need to know basically the squares of a lot of numbers, okay, which you memorize, literally.
Which I have, but then
Yeah.
my friend was asking, how do you find that? I was like, I don't know how to explain it.
Yeah. Well, if you know, you know, and if someone really wants to know what the exact amount is, the exact square root of some number, let's just say 240. What's the square root of 240? Well, there's a couple of things. If it's a nice even number like 240, we can factor it and look at it and say 240 is 2 times 120. Okay. It's also 3 times 80. Okay. So you can pull it down a little bit. But if you know that the square of 15, for instance, is 225, and then the square of 16 is, I say I've memorized them, but I haven't memorized all of them quite clearly. But the square of 16, if you multiply 16, if you multiply 15 times 16, you got 225 plus 15 is 240. So the square of 16 is 256. So 240 is somewhere between 15 and 16. And how far is really the it's not a smooth transition. You can't say it's okay, it's about halfway, so it must be 15 and a half. It doesn't work that way. But you can approximate it. You can say it's around 15 and a half. But without a calculator, most people, I wouldn't try it, except for numbers that I'm familiar with. And there's ways of, it's easier to square a number than it is to figure out a square root. Even in your head, it's easier to square a number.
Well, the way my dad always explained it to me was You take a number and you multiply it by itself. And that's how you square it.
Mm-hmm.
So if you do it backwards, that's its square root. So like 100,
Yeah.
it's 10. Because
Yeah.
10 times 10 is 100.
So if you know those numbers,
Yeah.
then it's easy enough to do. But if you don't know those numbers, then you have to look at what are the squares on either side of it. And then you know it's somewhere in between, and you can approximate it. You know, it's not a smooth, as I say, it's not a smooth transition.
Wouldn't it be closer to like 15.3 or something?
Might be. I don't think so, but it might not. Yeah,
No.
see?
I'm
So it's
pretty
more
close,
like
though.
15.4. Yeah. So it's probably not 15.5. So it's somewhere between 15.4 and 15.5. Yeah. So you can approximate it. And for many purposes, that's all you need. You know, part of the problem is we think we have to have exact answers.
Yeah.
And many times we don't.
Like the square
Now,
root
for
of-
calculating doses, you need an exact answer.
As I'm sitting here like trying to get the exact answer.
Well, you can play with it all you want.
We're closer.
Yeah.
I think my friend is like the type of person that like shoots at numbers and gets confused.
People do. 15.492. So close to 15 and a half. See, when I said about 15 and a half, that was fairly close, right?
I got really
You got real anal
invested in
about that one. Yeah. Okay. So I'm recording again. So let's talk about a couple of things. And what I want to do is bring up, and we're going to talk about chapter 13. Note that, again, this is a third edition. I finally got access to the more recent edition. So the next time we meet, I'll have updated PowerPoints. Do people choose their own health? What do you think about that question?
Definitely.
How?
Your lifestyle.
Okay.
I
And I
think
mean,
it's
there's
a
things
yes.
that you know you should do. You know, don't drink enough water, and eat too much McDonald's and stuff like that. You could definitely make it yourself a lot. You could make your health a lot better.
Yeah.
I think everybody could.
I
Yeah.
think it's a yes and a no.
Mm-hmm.
Just because there are diseases, there are health issues that people choose, like eating McDonald's and getting, heart disease from eating too much of it, or getting fat off of it and then having other health problems from that. But there's also, some of the more mental disorders. I don't think anybody chooses to become schizophrenic. That's generally something you're born with that may develop later in life. So I think that's a hard one to say yes or no to.
Like anything else, there's a lot of gray area. Yes, there are genetic diseases. We don't choose to have genetic diseases, although my naturopath likes to say genes don't have to express. And why is it that someone with ostensibly similar genetic makeup, I'll use my family as an example again. My mother had severe rheumatoid arthritis and ultimately led to her death from medical treatment, essentially. The younger of my two sisters decided years ago that she was going to have our mother's disease. I decided I wasn't interested. I have the usual arthritis that comes with living as long as I've lived, which means my joints hurt now and again. My knees especially protest when I go up and down stairs sometimes. But I don't have rheumatoid arthritis. My sister does. She's younger than me. So we can influence the expression of our genes. It's called epigenetics. It's a whole science of, epi means beyond, and so it's the whole science of how things that are not the DNA can influence the expression of DNA. But you know, a lot of things, if we look at this list in the PowerPoint that you have, which you can access through week 2 readings and tools, the second slide lists leading actual causes of death. Virtually all of them, with the exception of microbial agents, are lifestyle. Tobacco, poor diet and physical inactivity, alcohol, toxic agents. And again, one can say that's kind of iffy. There's not much we can do about air pollution as individuals. We're not going to run around with gas masks and oxygen masks.
No, but if you're, using drugs.
Yeah. Motor vehicle accidents, firearms, sexual behavior, illicit drug use. Many of these things are indeed lifestyle diseases, or the lifestyle stuff. Tobacco, we know, causes an incredible range of diseases, and 480,000 deaths a year from that are directly attributable to the use of tobacco. That list that I just read account for almost half of all deaths in the nation. Many are preventable. Most of them are what we call premature. Now, considering that there are people who literally will live for a certain amount of time and then they'll just drop dead. We don't know what that really means. But we do have an average sort of lifespan. So if the average lifespan, which a couple of years ago had been raised in the United States for men or on average to be 79 plus years, the average lifespan is 79 plus years, and you die in your 40s, we'd call that premature. If you died at 75, I don't think most of us would think that was, a significant early death. You may not want to see that happen, but if the average is 79 and a half, there's got to be a distribution. And essentially all of them are targets for public health intervention. Tobacco, we'll talk about that later. But the list of diseases grows every year that we've now related to tobacco. And if you've looked at my my initial post on this week's discussion, I've told you a couple of stories in there about tobacco. But there's a lot more information. I really don't want to get into that too deeply because we're going to have that as well. We also will be discussing the poor diet and inactivity, which leads to many things. Heart disease, you're right about that, Richard. Diabetes, cancer, all of these things come about because of not strictly, but they're implicated. Our lifestyle leads us to be more likely to suffer these kinds of diseases.
The obesity one is a really big thing with like the WIC and food programs.
Yeah.
My daughter actually got an extension on whole milk from WIC because she was sick for about 3 months. Nothing dire or horrid, just discovering allergies essentially. And
what we used to call poorly.
Yeah. and she wasn't gaining weight.
How old is she?
2.
No, that happens.
I wasn't terribly concerned, but her doctor and the WIC lady seemed very, very concerned.
Yeah.
Of course, me sitting there going, she'll eat us out of house and home if we don't stop her every now and again.
Yeah.
Apparently didn't mean anything.
Well, one of our daughters was the same weight from about 2 to 5. And nobody was worried because she was healthy.
Yeah. Well, and that was
You know,
the
she
thing.
just
was like,
wasn't growing. And then she grew.
yeah. But they, I asked, why are you, I mean, not that I mind, I love whole milk, and so does my daughter, but why are you keeping us on whole milk when it's policy to drop us down to 1%? And she's like, well, we need her to gain fat. And I'm sitting there going, if she was going to gain fat, it wouldn't just be from milk. It would, like,
Yeah.
there was all of these things she was quoting at me about the foods that they say yes and no to. And the entire time I'm just sitting there going, I don't think these things really make children fat.
No, but they put calories in.
Right.
And really, that's, if they were really being objective about it, that's what they'd be saying. We want her to increase her caloric intake.
Yeah.
Milk is probably not the best way to do it. However, milk does 2 things. It gives them hydration as well, because of course it's mostly water.
Yeah.
If you can get them to drink milk, then they're going to be getting sufficient water. It's something that, unless kids hate milk, they'll drink it all day. So, but I'd probably be more interested in feeding her, full fat cheese if you were interested in fat, in calories and fat.
Yeah.
Full fat cheese, forget hot dogs, not good fat.
Yeah.
But if you want them to have fat, so nutrition is another public health issue, really. And the nutritional service, the National Nutrition and Health Center or whatever it is.
Yeah.
There's a lot, again, there are so many myths about food and people buy them. I read them all the time and I just look at them and I say, oh, give me a break.
My favorite was the eggs cause cancer.
Oh, well, here's my favorite. I went to a seminar recently. A year ago, went to a seminar here in Fort Collins from someone who was talking about the health benefits of natural foods. All right, that's sort of in the medical realm, so the school was willing to send me to that. And I almost walked out on this lady when she informed the group that eating 1 egg was the equivalent of smoking 5 cigarettes. At that point, I was ready to walk out.
At this point.
Yeah.
Because that's her go-to.
Yeah.
Like when she wants a snack, she goes and grabs an egg, and it's not hard boiled or anything. Cook it for her, and that's her favorite thing is eggs, and
But that's what this woman had on one of her slides, and at that point I said, "You are a flake. I don't know where you're getting this, but I don't believe it." And there are lots of things that people make in terms of claims, and a lot of it comes out of a seminar like that. She was, there were people in the audience that were eating that up, literally, and I'm sitting there saying, "Do you people ever think?"
Mm-mm.
And I'm sure there were other people in the room, because I saw a couple of eyes roll, but I'm sure there were other people in the room that were thinking, that's not right. But we do have so many myths. All of the fad diets just drive me nuts. They don't work. The best diet eat less, eat balanced. Who cares if you have a hot dog now and again? We're talking about the whole picture, you know? And in reality, you know, that's really what, and exercise.
Oh yeah, my little girl never stops moving.
Yeah,
And
well,
That was what I told the WIC lady and her doctor. I was like, she doesn't stop moving. Yeah, she's eating like a horse, but she's working it all off.
yeah. Kids do that. Let them.
I could pump her full
Yeah,
of calories and she'd run them out at the end of the day.
sure.
By the end of the
And
day.
let them. You know,
Yeah.
pretty soon, soon enough, they're going to be stuck in a classroom sitting in a desk not getting any exercise. When they've cut PE and everything else out of the curriculum,
Mhm.
you know,
My
Let her.
nephew, he's-
okay. Alcohol is a major issue. And it has lots and lots of, you know, things and denial. I mean, again, if you read, you know, there's all sorts of things about alcohol, but now I've been reading some of the latest research and the myth of moderate drinking. You know, it's not good for you. Alcohol is a toxin. So, you know, when I drank, I loved a cold beer on a hot summer afternoon. I don't figure a cold beer on a hot summer afternoon is going to kill me. But, you know, when it turns into a pint of bourbon a night, then we've got a problem to deal with. You know,
It's just like chocolate's good for your heart. Well, maybe, but the amount you have to eat would not be good for you.
and it's only dark chocolate, preferably, you know, 80% or better. Yeah, that's good for
It's
you.
like now they're saying that pregnant women can have a glass of wine. And it's like, I don't trust that.
Yeah, alcohol's effect on fetuses is well established.
Yeah, but now they're saying that a glass of wine.
Again, a glass of wine, I can understand why people would say that.
Mhm.
The problem is, you know, you're better off not doing anything to your fetus, period.
Well, it's like my aunt, she didn't start drinking again until her daughter was weaned off breast.
Mhm.
She refused to, even though her doctor was sitting there going, if the baby's really having that hard of a time sleeping, have a glass of wine an hour before you breastfeed.
Yeah.
And I got told the same thing. Like, we had kids 20 years apart, and the doctor was telling me the same thing, and I'm sitting there going, drink wine, potentially poison child.
You know, remember what they used to tell us about when our kids were teething? You
Put
know,
whiskey on their gums.
yeah, dip your finger in a bottle of whiskey and wipe it on their gums. Quite frankly, I actually told the doctor this, and I said, you know, I think it would be much more effective for me if I pulled out the whiskey, poured a shot, and drank it myself, and then put the baby to bed. I'd probably be better off. He didn't like that answer, but a lot of my doctors don't like the answers I give them. So interventions, what can we do about these various problems? These are only a few of the problems. I mean, clean water, clean air, access to health care, the immunization program, all of these things are critical. They have been shown repeatedly to change our health. But what can we do? Well, there's education, regulation, or prohibition. Well, we tried prohibition in 1919. 14 years later, we repealed it. Did alcohol consumption go down? Oh, yeah, significantly. Did cirrhosis the incidence of cirrhosis and alcohol-related disease go down? Near as can be told from the records, significantly.
But crime went up.
Crime went up, you know. John Kennedy became president because his daddy got rich running rum. You know, he became president a few years later. But it was because his daddy got rich as a rum runner, smuggling booze into the U.S. So, didn't work.
And they say
Prohibition, the war on drugs, has been an expensive flop. You know, so prohibition doesn't work. Control, yeah. What we can do is education. Education's the key. You need to tell people. It needs to be from day one. We need not to be putting restrictions on what can be taught our kids
Oh, God. That's a
in terms
losing
of
battle.
these things. But we provide the educational information. We look at diet and nutrition, get people used to eating good foods. When our kids were growing up, we never had sodas in the house. And the rare occasions they were allowed to have soda, which we did, we weren't Nazis about it. The rare occasions they had soda going out that was their treat. Never diet soda. Never any of that crap in our house. So, you know, and to this day, we have kids who generally eat very healthily. Will they go out and have, you know, fast food sometimes? Oh, you bet. Okay. When they have an opportunity to have something tasty and new, you know, we were in Santa Fe a few weeks ago, the weekend of the Hispanic market. Actually, it was great. There's a place there called Santa Fe Bites, which is a restaurant right off the square. They have the best green chili burger, and this green chili burger, we're not talking about the green chili sauce, you know, that's mostly flour that you get up here. We're talking chopped green chilies, just the best. And so we all had to go have a hamburger. It was one of the best hamburgers I've ever had. Nothing wrong with that. We eat fruit for breakfast a lot of times, you know. We taught our kids to eat well. We also didn't make it a big deal if they went to McDonald's now and again. We'd say things like, ugh, you know, but if they did, they did. That was their choice. Consequently, they don't go there. And in fact, mostly they don't go to fast food places because we never did it. They learned the value of a good salad. Plus, you know, we always cooked fresh food. We can afford it. Now, I know people who can't. So it's kind of tough. So health education in schools, health education in general is a bit controversial, but sex education is the most. And yet, what happens? We have one of the public health crises in this nation is teen pregnancy.
And yet it's at the lowest rates it's ever been in the U.S.
Because we denied it. It's at a rate that's really not good. Okay?
Yeah.
It's at a rate that's unacceptable. But we always used to deny it. When I was a kid, someone got pregnant. Well, they went and lived with Aunt Tilly for a year. And then came back. And, you know, nobody said anything, but everybody knew. You know? So that child is now was then up for adoption. And nowadays, we've also heard stories of a friend of ours was talking about one of her neighbors who knocked on the door one day, walked, and there's a woman there, and she says, "Hi, I'm your niece." Her sister had a child as a teenager, and that child was taken and adopted out, and through, you know, Ancestry.com or one of those, discovered that she was related to our friend's neighbor. You know, and that's got to be a shock. You open up the door and there's a stranger saying, "Hi, relative." Oops. So we have a different attitude about it now. It's more acknowledged than hidden. And it's a hell of a lot better than things in Ireland, if you've been watching that news. The homes for unwed mothers, the death rate of the children in there was exceedingly high. And they just found a mass grave with like 600 remains in it, in the bottom underneath one of these homes. And it's causing quite a scandal. Oh yeah, yeah. And the one of the cabinet members of the Republic of Ireland has gone to the Pope and said, "We want the church to pay part of the reparations for this." So it's kind of interesting. So we are changing. Also, physicians need to be involved. Regulation. We have lots of regulation. We restrict sales of alcohol, drugs, and tobacco. Does it stop anybody? No.
No. Makes them very, very angry at the pharmacists and pharmacy techs. So.
Yeah, I'm not surprised.
Well, we had a lady that came back and we had to take her ID because she was picking up morphine. And she asked if she could buy her cigarettes back there. It's a no-no in Walgreens.
Yeah.
We are not allowed to touch the tobacco products. So like, even if they bring us like the Nicorette gum or something like that, we are not supposed to bring it up.
Oh, really?
We have to tell them to go up front. And it's not because we can't check their license or put it into the system or anything like that. It's just, you guys do drugs. We'll handle the rest of it. And there are a lot of people that won't pick up their medications and cigarettes at the same time because they don't want to have to come back to us, swipe their card once, and then go up and swipe their card again.
Well, those are the rules.
Yep. They don't want
You know, and well, you know, that's, again, those are choices, and people need to learn to pick their fights. But anyway, we've tried, but it's kind of hard. Tobacco sales are one that's very clear. Restrictions on ability to buy tobacco hasn't stopped people from getting tobacco products at an early age. They just have somebody else buy it for them.
Oh, no, what they do is
alcohol too, yeah.
No, what they do is they have the neighbor or the aunt or the uncle that smokes and buys it by the cartons and, oh, a couple packs went missing. Well, they smoke like a train. They don't notice.
There's that, but also people will buy them for them.
Hmm.
You know, and alcohol's the same way in drugs. Drugs, you know, you can put all the restrictions you want on drugs, but if people want them, they'll get them. They can find them. Same with alcohol and tobacco. We put age restrictions on things. It's easier for us to restrict driving than it is to restrict access to alcohol and tobacco products in young people. And then just try to regulate sexual behavior.
It doesn't work.
Yeah.
They have this thing called a chastity belt.
Yeah.
It doesn't work.
Yeah. A locked room and feeding through a hole in the door. That's the only way it works.
Well,
which I
don't
don't
know.
advocate, of course.
With YouTube teaching people how to make little tiny bombs to just blow up a certain part of the wall, I think it would still fail.
This is true. All right. So let's move on to a different chapter. In this case, chapter 14, which is psychosocial factors. We're not going to spend a lot of time on that, but here is where behavior and the socioeconomic status come in. The health is affected by that socioeconomic status. The lower you are on the socioeconomic totem pole, the worse your health is liable to be. But gender, marital status, race, ethnicity, all of these things are factors in in the access and the utilization of healthcare. And those disparities really affect the whole society, not just a small group or a large group of people who fit into a category, because it affects everything up and down the economic chain. It affects the cost, the overall cost of healthcare. A lot of it is people still occasionally have to go to the ER, and just because they can't pay, they can't be turned away. Okay, that's not legal. So if a hospital gets to eat it, well, then somebody else gets to pay it. If nothing else, the taxpayer. But in reality, it's mostly those of us that are buying health insurance. So nutrition is a big issue, especially in the lower end of the socioeconomic scale. People can't afford to buy good food. And in fact, years ago, I found out that if you go into King Soopers and do a survey of King Soopers in a city, and I'm talking about, in this case, Denver, Aurora, in the more upscale white neighborhoods, the stores were cleaner, newer, nicer. The vegetables were fresher. And as the vegetables began to age on the shelves in a King Sooper, they would move down to the next lower neighborhood, and so on, until you get into the really poor neighborhoods. And some of the stuff you and I would look at and say, I can't eat that. And yet they'd sell it. Would they cut the price? No. Same price all over the city. Tomato's a tomato, right? No. The tomato over there is nice and fresh and it's red. May not have any flavor, but it's nice and fresh and red. The tomato over here is kind of beat up and not quite so red anymore and squishy and not good. Same price, no way.
The King Soopers in Longmont, that's on the south side of Longmont, got called out on that.
Good.
Because they were sending all of the stuff that they didn't deem shelf worthy up to the North Store.
Yeah.
And the North Store had enough of it. They're like, we don't want your crap.
Yeah.
Like, our stuff because both stores, it doesn't matter which one you go into, it all looks good. But the South Store was sending everything that they didn't want or didn't deem shelf worthy. Like boxes that had a tiny little tear and crap like that. And it was ridiculous.
I think there's supposed to be a place in Fort Collins that gets all the fruit or stuff like that that doesn't look like they want to put it on the shelves, but it's for a reduced price also.
Mm-hmm.
Yeah.
The North King Soopers, when they do their clean outs, because they're still a corporation, they have their rules and regulations. They worked it out with the city to give all of that to the food bank. So a truck comes when they do their clean outs and takes all of that to the food bank.
That's what it should be.
Yeah.
Yeah, and a long time ago too, like the restaurant, all the food we scrape off the plates and all that, we give them to the local farmers, for the pigs and stuff like that. And some of the stuff that was left over, like I think we make like fresh beans every morning, so if there was beans left over, and they were fine, but we weren't going to keep them, and
you can't.
we were able to give them away, but then they changed all that. You couldn't even give the stuff to the farmers for the pigs. Can't do everything, has to be thrown away. It's like,
Oh yeah, Longmont kind of ignores those rules. I'll be honest about that. Longmont ignores those rules. You'll find officers who will actually stand outside the backs of restaurants while the restaurants are like, hey, this is all of our leftover.
Yeah,
to the homeless people.
yeah, you know. that would
And
make
the
sense.
officers stand there, and anytime the radio goes saying something about, you know,
Mhm.
complaints about homeless people in this area, we know we've got it.
Yeah, it just makes sense, right?
Yeah.
You know?
Yeah.
When I was working at TGI Fridays, that's what we did. When we cleared out the bins every night, we put it on plates, paper plates, granted,
Yeah.
so they were easier to get rid of. But we put it on plates and take it out. We had a table, and we'd just wait. And eventually, you'd have people come walking through, and it's like, here's your dinner.
Well, you know, there are places like Denmark, where my daughter and son-in-law live, require that. You may not throw food away.
Yeah.
It must be given away. Okay, so there's a lot of other things that affect health as well. Stress is one. There's lots of things that cause stress. You know, in our lives, it happens, and some are short term. You know, our daughter's wedding was a big stress for a short term, and we could see an end to it, so it didn't bother us. You know, however, there are other things, illness in the family. We have a different stress. My mother-in-law, that's a stress, and it's a long-term stress on us because it restricts us. You know, we do this willingly, but we feel it. Okay? There's lots of things. Illness is a stress, divorce, death, whatever. There's lots of models. We won't go into some of the models, but some of the things, one of the ones that need to be thought about as a current model is what they call the ecological model of health behavior. There's the level of the individual, your own psychology. There's the family, friends, and coworkers, what we call FFC. That is a network that influences your health, good, well, or negatively. The institutional level, being at school, being in the workplace, the influences on your health that come from stress is part of it, but also the guys that say, hey, it's Friday, let's go have a few beers, you know, encouraging the kinds of things. Then there's the community level, which has both positive and negative, you know, churches, community organizations, neighborhoods, both positive and negatives. And then there's the public policy level, which is government, regulations, and government rules. All of these influence our behavior and our access. And they all have their own particular effects. Sometimes these effects can be positive. Sometimes they can be negative. When the public policy gets in there, politics gets involved. And so when New York tried to put in place some closures of bathhouses for you know, gay bathhouses and that sort of thing, the politics forced them to stop that effort. San Francisco had the same problem. But what they did was they put in rules that made it a requirement of these places to restrict the riskier behavior. And over time, these have worked. Ultimately, New York was able to get rid of its bathhouses. There are lots of things that are done. We've talked about tobacco control. We change our environment because we can't change individuals. The individuals are going to do what the individuals want. We have a society that thinks that they're supposed to, you know, people are supposed to be able to do what they please. This is it's a mixed bag. We don't want to have our government legislating how we live our lives. We don't want a 1984 scenario. But we also don't want a free-for-all, because that anarchy has never led to anything good. So there's a yin and yang. There's a real love-hate relationship between between the various parts of our society. Those that want to put programs in place that that restrict us. You know, access to alcohol, seatbelts. That was one of the biggest things. Motorcycle helmets. It is a law you're supposed to wear motorcycle helmets. Whoever gets arrested for not wearing a motorcycle helmet. At least half the bikers I see are not wearing helmets.
My uncle got pulled over for it and ticketed.
Good. When was that?
2 years ago.
Really?
And it just happened to be like that one day that he wasn't wearing his helmet.
I thought the law was you didn't have to wear
The law has gone back and forth. When the law was passed, you had to. But I think it may have been modified. But there is, you know, first off, the problem, of course, is that if you have a motorcycle accident at 70 miles an hour, you're probably going to be dead, helmet or no. However, most people do not. Most people become very severely injured and become a drain on family and the society. A head injury is no laughing matter. And a more severe head injury is very, very much a problem. Plus you have spinal cord injuries and all the other things that are associated with that. So I think Colorado actually has a law on the books about wearing helmets.
It's
I know.
kind of up to the county.
Yeah.
Is kind of that's how Colorado law is kind of stated as far as the helmets go, is that it's a county to county decision. So like Boulder County, oh yeah, you better wear your helmet. They'll pull you over and ticket you so fast, it's not even fun. But
Well, it doesn't happen in
if
Larimer County.
it.
But I know, like, if you go down to Denver and the surrounding cities, cop's gonna sit there and watch 10 guys go by with no helmet and be like, all right.
Yep.
But I think part of Boulder County's thing was also, not saying we don't have wrecks, but we tend to have less wrecks. So the cops were like, we need something to do.
Could be. But other things we've had, you know, we've been trying to, you know, we put restrictions on, you know, access to alcohol and tobacco. We have used a lot of educational efforts to reduce the incidence of driving under the influence. And now, you know, when someone is drinking, a lot of times people will make sure that they're not driving. And responsible people, there's a whole program for a long time of, okay, it's your turn to be the designated driver tonight. You're drinking Coke. You know.
Bars in Denver will actually waive the drinks for the designated driver.
Oh yeah.
That's how it is in a lot of places. You're not ordering
Yeah.
alcohol.
Yeah, I mean, well, the mixers are, you know, pennies. And if there's somebody there who's driving, they know somebody else is going to drink more.
Yeah, that's true.
So they're going to make
Well,
more
Yeah,
money.
and soda,
But-
that was the biggest moneymaker at the restaurant. So
Yeah,
you can give that big old cup for $1, and even if they drink another one, but you know that's pretty hard to do plus food.
Yeah, well,
So
and like,
that
um,
soda is the biggest moneymaker
the club that
everywhere.
the
Yeah.
club that me and my friends used to frequent, they'd give you this bright red bracelet. But it wasn't like those cheapy rip-off paper bracelets or anything. It was actually like a really nice bracelet. Like I still have mine and wear it on occasion. But they ordered and made these special bracelets that marked you as the DD. And you got free drinks, you got free entry. I
That'd
mean,
be cool.
it was like, oh, if you're going to be the responsible one,
Mhm.
Yeah,
by all means,
come on
come
in.
join us.
Yeah, we'll keep you
So-
here as long as we can keep them drinking.
Yep, pretty much.
And, to some extent, that's worked. But we still have an issue with drunken driving.
Well, you can't control the home activity is the problem.
Well, and you can't, you really, the only thing that can stop a person from drinking in public is if someone won't serve them. And a lot of bartenders, now in some states, there have been lawsuits against bars for the bar staff to serve someone who then goes out and kills someone or is killed or injured or whatever. So in some places they're pretty aggressive about saying, nope, you're cut off. And
We had Vicky for
pardon?
that. The one bar I worked in, we had Vicky. She was a little old Italian grandma. And when somebody would refuse to be cut off, we'd send Vicky to go deal with them. And next thing you knew, they were drinking coffee.
Yeah. You can quit drinking or I can call my brother Guido.
We're actually not sure how she did it, to be honest.
Well, she probably just was being a grandma and it was,
That's the
you
only-
will stop.
Probably.
There are people that you just don't argue with. Anyway, so we've got lots of different kinds of programs, but I really wanted to get into now chapter 15, which is, we want to do this, and this is public enemy number 1, tobacco. Remember, this is an edition that's about 7 years old, but deaths from smoking range from cardiovascular disease, lung cancer, to many other cancers, diseases in infants from secondhand smoke and from smoking by the mother, burns that come from accidents. My sister burned her apartment down by going to sleep with a lit cigarette. She and her daughter didn't get hurt, but, she basically closed an apartment building in Northern Virginia.
That was our fear with my grandma.
Yeah, it is. It's a fear. Smoking is something that's really a 20th century phenomenon and later. The rolled cigarette machine was invented in Durham, North Carolina by Washington Duke of the American Tobacco Company in the 1880s and created one of the largest fortunes in the country. Quickly, other people developed their own cigarette rolling machines, but at one point, the Dukes had 95% of the rolled cigarette business in the world. And they were one of the first companies busted up under the Sherman Antitrust Act by Teddy Roosevelt. So the Dukes did something really unique. They decided, okay, we're going to sell off, we're going to have a boatload of money. So they spawned Liggett and Myers and R.J. Reynolds and, half a dozen tobacco companies in North Carolina, and they got a ton of money. And so they decided that they wanted to get into this new stuff called aluminum. And they founded a company that they called the Aluminum Company of America, Alcoa. In order to do aluminum, you need electricity. So they founded Duke Power, one of the Southeast's largest power corporations. So North and South Carolina were some of the first states in the nation to have municipal electricity and electric lights in homes, electricity in homes. So the Dukes made more money by having their company broken up than they ever would have made with tobacco.
Mhm.
So they did. So the Sherman Act was a favor to
Well,
the
when you're
Dukes.
smart
But
about it.
before that time, tobacco was either chewed or was smoked in a pipe or as a cigar.
And it was natural.
Yeah, right. And then cigarettes came along, rolled cigarettes, and they didn't really take off until about World War I, when a brilliant marketing strategy was dreamed up by someone who, you know, if it weren't such a horrible thing, I would say deserved a big reward. Give away free cigarettes to soldiers.
Yep. And
And smoking rocketed.
when did they put all the chemicals?
That started happening in the 40s and 50s when they were doing that. I had a friend who worked in when I was in the pharmaceutical industry, and this story is actually in the discussion for this week that I posted. He worked. He was one of our researchers in one of our biology departments at the company I was working for. And he and I were talking, and he said, well, I used to work in the tobacco industry. And I said, what did you do? And he says, I was studying the health effects of tobacco on animals. And I said, well, why are you here? He said, I wanted to present my results, and they suppressed them, and they threatened me if I presented them because I had a contract that said I would not present any of my results without their permission. So I quit. And that was the first time I heard definitively from someone who knew that everything we'd suspected, which was that the tobacco companies were hiding and lying, was true. Okay. So tobacco, that's really when they started enhancing with extra nicotine, with other things, menthol cigarettes. You talk about something nasty.
Fiberglass.
Yeah.
Or is that close?
Filters. Pardon?
There's one of the flavored cigarettes that you're quite literally inhaling fiberglass because that's what the flavoring is. I think it's the clove cigarettes.
Well, but in 1964, when the Surgeon General released the first report on smoking in America, roughly half of adult men smoked, and about a third of adult women.
Oh yeah, if you see any of those movies from the 40s and 50s,
Everybody's smoking.
Oh, and now see all those
Television shows from the 50s. Everybody smoked. Television commercials. You couldn't advertise a drug on TV, but you could advertise cigarettes. Now you can't advertise cigarettes, but you can advertise drugs.
Well, and
Go
now you
figure.
And now you can't use cute little animated creatures to do your advertising for you.
Well, not since they retired Joe Camel. No.
And Budweiser Bullfrog.
Yeah. But many, many diseases. The list keeps growing. Even then, we had already linked smoking with lung cancer. And there was a myth at that time that women were somehow immune to the effects of smoking. And the reason was that women in large numbers weren't smoking until World War II. The men had gone overseas, the women were working in the factories, and they started smoking. And so in about the 70s, we started seeing those lung cancers in women. In fact, more women die from lung cancer than breast cancer now. It's because of smoking. So there are multitudes of diseases, metabolic diseases, cancer diseases, cardiovascular, we all know, COPD, emphysema. I can remember one of our research directors that I had worked for years in the pharmaceutical industry smoked like a fiend. And I went into his office one time, to talk with him about a project we were working on. And I looked at him, and there he was. He was take a hit on his cigarette, and then he'd take a hit on his oxygen bottle because he had emphysema. And I looked at him and said, "Howard, what are you doing?" And basically he said, "If you mention it to me again, Mike, I'll fire you." So, okay, Howard, you win that one. You're the boss. But it is addictive. Okay, and there's all sorts of other things that come about. The harmful effects are just ubiquitous. Why the only reason they haven't been banned is because economically they're too valuable. Smokers, the cigarette companies, between people dying and people waking up and quitting, need to recruit 2 million new smokers a year.
Well, I don't remember what the date was in the late 90s or early 2000s, whenever they did the federal thing, no more smoking in federal buildings.
Mhm.
And so every building on the base is a federal building. So they took it out of the golf club. You got all those retired generals, especially at Fort Sam, because it's a place for me. So
Yeah.
all those retired generals. And not only that, but then that basically supported all the morale, welfare stuff on the base, because that's where they made all the money, was on the golf course. So 2 weeks later, they had the cigarettes back in there.
Yeah, I believe it. I believe it. Okay, so we talked a little bit about the history. Many efforts have been made to curb smoking.
I
There's
think the Australians have it the best. Jack up the prices until nobody can afford to buy it.
they do that with a lot of things. In Australia, it's perfectly legal to own guns. They don't allow automatic weapons, but Australians have the same rights to own anything that's not an automatic weapon as we do. It's just that they can't afford the ammunition. The price of bullets is so high that only people who are hunters and good shots will buy them. Okay, so yeah, they do that a lot. Smoking, the taxes on smoking in Europe are very high compared to the taxes on smoking here. People come from Europe and they'll go back with cartons of cigarettes, such that Europe has put restrictions on the number of cartons you can bring in. Yeah.
Plus, I mean,
Well, it depends on.
the cigarettes here taste a lot better. It could be the same brand, it tastes a lot better from here, you can tell. But
I don't know. When we went over, I was 16 at the time. I preferred the British cigarettes.
Some people do.
And,
they all taste stale too.
Yeah. There's
well,
They're formulated
figure how
a
long
little
they've been sitting
differently.
on that shelf.
and they're not. Many of them are non-filtered, which is a big part of it. But lots of efforts to curb advertising, to preserve the rights of non-smokers not to be exposed to environmental smoke. Lots of efforts have been made. And yes, smoking has declined, but there's still a lot of smokers. And the rates also differentiate by ethnic group and racial group. Smoking is higher among Black men and Native American tribes. But even in those, the rates are declining some.
Well, because now you have all the little Black grandmas that are like, "Don't you smoke?"
Well,
I've never stopped any of my friends.
and the price too.
Yeah, the price has really done it. Where are you going to see more smoking is when people don't have high taxes, like military, on smoking, and other places where they're tax exempt. That's another reason that it would happen. But one of the problem is that we we try to recruit youth, even though it is illegal to target youth. There's lots of ways to do it. You make it cool. You do a lot of different things. There really is no excuse for anyone taking up cigarettes as a youth. Addictive behavior, addictive substances, when started in the 12 and under set, takes about a week to get addicted, and that's cigarettes, alcohol, drugs, any of those, because our brains are not developed. Between 12 and about 20-ish, it takes about a month of steady use to start a person down that addiction road. If you don't start any of these until 25 or later, it's hard to get addicted. You have to really work at it. Can you do it? Oh, I guarantee you can. But it's real, but you have to be focused on doing it. Almost like you want to become addicted.
I was pretty lucky. I think the most I smoked was probably 3 cigarettes a day. And then I was always able just to stop whenever.
When did you start?
Not until I got in the Army after high school.
Yeah, right. So same with me. I smoked for a few years, and I started in the Army. It was the only way we could get out of the barracks in basic was if we were actively smoking, which is really stupid if you think about it.
Well, there used to be, if you were an officer or a E5 or above too, if you went somewhere and you didn't join the club, you might as well, if you're going to try to make a career out of it, you had to.
Yep.
And then you go in there and you have all these cheap drinks. And,
cigarettes.
Especially if you're in Germany, it's really cheap. So they stopped doing that though, because that was a problem.
Yeah. Alcoholism is a major problem in the military. Always has been.
And in Germany, that stuff is so cheap because there's no taxes.
Yeah.
You
That
get
tells you-
a gallon-
that
get
tells you
gallon
how
each
expensive
ground
it
for
really
well,
is
it
to
used be
produce.
$4 or $5 now, but it's 10 now.
Yeah.
That's just super cheap.
Oh
Yeah.
no, the prices really have not gone up that much.
Jeez.
We
You can afford
my-
not to drink over there.
well, and I mean that's essentially how alcohol started. It was safer to drink than the water.
Yeah.
But my ex-husband and his buddies, they drink this beer called Golden Drop, and here it's $25 for a 4-pack.
Mhm.
But over in Germany, it's $6.
Yeah.
For a
Right.
6-pack.
So one of the strategies has been to tax tobacco. That always has been attractive to politicians because, of course, it gives them money, right? The problem is that they, just like with the marijuana here in Colorado, they push it as a way to do something that they think people want. In the case of marijuana, the money was supposed to go to schools. It hasn't.
Yeah.
This state has raised almost $1 billion in taxes from marijuana already. The schools haven't seen it.
Well, but that's not just like the school's fault.
That's the state legislature's fault.
Yeah.
So the way they
'cause
made the
the-
laws is that they can't update anything. It has to be like a brand new school. They can't go in there and remodel stuff,
Yeah.
which is, come on.
Well, and the other problem with it is that, okay, you can have that money, but you may no longer be federally funded. You can use that tax money, that's fine. But we may choose not to federally fund you anymore.
Yeah.
So it sits there and does nothing.
So again, and after during the whole run up to legalizing marijuana, that's what I told our friends. I said, we've heard this story before. Oh, it's going to go to the schools. When did it go to the schools? So anytime you hear a politician say, I want to raise taxes on this, I want to do this to make money, and the money will go to schools, you know they're lying.
Mhm.
But it's this, because my nephew's school got rebuilt by the taxes from marijuana. And it was they said that the small towns that don't have dispensaries is where the money from the taxes from marijuana goes.
That's interesting.
'Cause
Because
a lot of
I
the-
guarantee you
that might
Loveland
be-
hasn't seen that money.
No.
And Loveland doesn't have any marijuana dispensaries.
I was gonna say, because really too, there was the dispensaries in Evans, like right there close. And I think really thought they were gonna get some of that money. They don't get none of it. So if you were living in Evans,
It's the smaller towns, because Hudson.
Well, I think
that's where
more
he
what that
goes.
is that
And it's
they
in
were
the
rebuilding the
newspaper too, like their community newspaper, it's in there that the taxes on marijuana pay for the.
Well, that's interesting because that's the
Well,
first
but
I've heard of that.
what that might have been
So-
was less, it goes to the smaller towns and more, well, we can either use community money or federal money to rebuild the school
yeah, the
because
smaller towns might not have the
legally,
numbers for federal
the
money.
state and the government have to do that.
Yeah.
You have to have a school accessible to those children.
Yeah.
They had
Well,
to
why would we use
rebuild it
our
anyways.
money? Right, but this is like, this, I think this is where they're coming from, is why would we use our money when we have this giant pool of money that hasn't been touched because we're so smart?
I need initials from the three of you on these. You all recognize the 2-minute meeting. Richard just reflects where you were at the end of the week, so I expect that will change. So it's time for the end of class. For those of you who watch the video, I want you to send me an email, and in the email, I want you to put the word MEDAN, MEDAN. And that way I'll know you've seen the class. That'll get you attendance. So,
MEDAN?
MEDAN, you don't have to do it because you were here.
Oh,
Yeah, but those who are listening to this outside of class. So we'll see you